Thanks for letting us know. I'll start over. Good afternoon. This is the Telehealth program, and my name is Colleen Crowley. I'm the Executive Director at the Northwest Parkinson's Foundation. And this afternoon we have Dr. James Leverenz as our speaker. Dr. Leverenz is a professor in the Department of Neurology and Psychiatry and Behavioral Sciences at the University of Washington. His research has focused on neurodegenerative diseases of adults with specific focus on Parkinson's disease and Alzheimer's. He currently directs the clinical research program for the NIH-funded Pacific Northwest Udall Center of Excellence for Parkinson's Disease Research and is the medical director for the APDA-sponsored Information and Referral Center. So, you can come over here a little bit. What we're going to do today is primarily just be showing the screen with his PowerPoint. And that's because technologically it works better for you to just be able to see that. So after I've introduced and gone through the preliminaries here, we're going to turn it back to the screen. Dr. Leverenz will talk for about an hour. And after that, as usual, we will have time for questions from each of the locations. So we'll be checking in with each location and getting your questions. So you'll need to hold your questions till the end. And remember, we'll come through then. And when we do, you'll need to unmute your microphone when you're asking the question and mute it when your question is done so that we can go to all the different sites. I also wanted to thank Booth Gardner Parkinson's Care Center for allowing us to broadcast today from Evergreen Hospital. And also for Parkinson's Resource Center of Spokane for all of your help. We know there's a lot of you folks there in Spokane that are always here. So I think with no further ado, we'll go ahead and I'm going to switch it over to the screen. And you'll be seeing again the PowerPoint. And Dr. Leverenz will be speaking. He'll be off camera, so you won't actually see him, but you'll be hearing his voice. Okay? Going the right way?
Looks like it.
Okay. I'm going to zoom out. At the top.
Maybe zoom out just a tad bit more. There, so you get a title up above there.
Okay, I didn't do your title either of your talk. Does that seem good?
That seems all right.
It's hard to tell.
Can you all read that?
I guess they can't respond.
Raise your hand if you can read it.
Okay.
We see some hands raising, so we'll assume that's okay. Well, thank you for the introduction, and welcome. I was talking earlier this week about our title here and realized that it was a pretty general title, so I've gone ahead and kind of changed it, partly because I want to focus on issues that I know something about, which are generally non-motor complications of Parkinson's disease. This is an area that I do most of my research in, and I want to talk a little bit about what these are with a particular focus on thinking skills, but also some of the other non-motor complications of Parkinson's, and also what we do in terms of managing that. So we will talk about medications, and I'll throw in, as we go through, some of the research that we've been doing or collaborations we've had with other centers around the country looking at these issues. So I guess I haven't strayed too far from medications and research. So just an overview, talk a little bit about Parkinson's. I want to spend some time talking about epidemiology because I think we need to recognize how important this disease is becoming. Talk about cognitive change. Is it a problem? How frequent it occurs? What's going on in the brain? Why do people with Parkinson's have some troubles with thinking skills? And then can it be treated? And then we'll talk about some of the other non-motor complications and a little overview at the end of some of our research. And then we'll be open to questions. I hope this won't take a full hour because I think everybody starts to lose it after about 45 minutes. So we'll try to keep it to that so that you're not all falling asleep. So this is a cartoon, if you can see it. This is a cartoon that my son pulled out for me many years ago, which I thought was very appropriate to epidemiology of Parkinson's. So the mouse is asking Garfield, he says, well, he's saying you shouldn't worry about turning 21. I had an uncle who lived to be 21. Garfield says, really? I remember what he always used to say to me. Garfield says, what was that? Who the heck are you? So people are always asking, how do I keep from getting diseases like Parkinson's disease? And to be honest with you, not getting old is sort of the main answer. We know that age is one of the major risk factors for Parkinson's disease, as well as other diseases of the brain, such as Alzheimer's disease. And we also know that the world is aging. And if you can see on this map here, you can see in blue are countries where an estimate is that over the next 15 years, there's going to be a doubling of the number of Parkinson cases. And you can see that's true for the United States, that's true for Europe. But what's really shocking is in red are countries where there's a more than doubling, and these are countries such as Brazil, India, Pakistan, China, really where most of the people in the world are living currently. So all of these countries that we've thought of as developing countries over the years are really where a lot of the population growth for aging is, and it's where we're going to see an explosion of cases of Parkinson's and other age-related disorders. So this is no longer an issue of first world. This is really a worldwide health issue. I think it's worth emphasizing that. So many of you know personally, maybe too personally, the classic, what we call motor symptoms of Parkinson's disease. And usually we divide these into four: the resting tremor, the increased tone in the muscles or the rigidity, the slowness of movement, often called bradykinesia, and the difficulty maintaining balance or postural instability. And in fact, James Parkinson, in his original essay on Parkinson's disease, described this very well back in 1817. So if you look at this first page of his essay, you can see he talked about the tremor, he talked about the trunk bending forward or the stoop posture, but he actually, at the very bottom of his first page, he felt that senses and intellects were uninjured. And I would say up until the last 15 to 20 years, that's generally what the field in Parkinson's believed, was that cognitive changes were unusual or uncommon and were not related to Parkinson's disease. For those of you who have read this essay, actually, you'll also know that most of the people he described he actually saw on the streets and refused to come in to see him in his clinic. So I've always argued that he wasn't able to really check their memory scores, but from what he could tell across the street, they were doing just fine. So let's talk a little bit about cognitive change in Parkinson's disease. First of all, I think it's important to start with definitions. What do we mean? Because I think that's very important, especially as it relates to Parkinson's, because what we define as dementia is often different than what people think of when they think of dementia. So as a doctor, what I'm talking about with dementia are two main issues. One is that there's been a change in thinking skills, a loss of thinking quality or abilities from a previous level, and that is sufficiently severe that it represents some, impairs some ability to do day-to-day functioning. And of course that's quite variable, right? You have a 90-year-old who's retired, living in a facility where he has a lot of support. Dementia is a different thing than somebody who's in their 40s and still running a company and trying to multitask. So sometimes it's very difficult. But I think the important part here is, well, two components. One is how do we define it? A loss of cognitive ability and sufficiently severe to impair activities of daily living, social functioning, but also that it can be relatively mild and we might still call it dementia. I have lots of patients who we've called demented as having a dementia affiliated with Parkinson's disease, who are still at home, still doing lots of tests, still enjoying life. They're not in a nursing home in a curled up position, but because they've had some decline in their cognition, because perhaps they can't hold the job that they were holding for a long time, it by definition fulfills the criteria for dementia, but that doesn't mean that that individually is profoundly impaired as we often think of with the term dementia. So we have to be very careful when we use this term, what that really means. Another term that we think we're often using now in Parkinson's disease as well is something called mild cognitive impairment. Something I think that's very common in Parkinson's, because a lot of my patients tell me, you know, there are a few things that I noticed that have changed since I've gotten the disease. Maybe I don't multitask as well, or I don't stay on task as well. But otherwise, I'm fully functional. I'm still even able to hold my job. I'm still, you know, doing the things around the house that I've done. I still can do the taxes. Maybe it takes me a little bit longer, easier to get off track. Those individuals we call mild cognitive impairment because there's some evidence that they've lost some cognitive skills, but it's not having a functional impairment. And that's something we see very commonly in Parkinson's disease. So those are our definitions. So keeping those in mind, when we think about dementia, and we look at people with Parkinson's over time, I think there has been a really dramatic change. A lot of it's driven by this study that was published in 2005 by Dag Arsland, a collaborator of mine who is in Denmark. And Dag looked at a population of Parkinson patients in Denmark. And in Denmark, you can get away with this because it's a national health system. You can essentially identify everybody with Parkinson's and follow them in a particular county, for example. And that's basically what he did. So it was a much stronger study than we could typically do here in the sense that he essentially followed everybody with Parkinson's. And what he found was that by about 15 years of disease, so as you can see on this chart over here, close to 80% of his Parkinson patients by 15 years of disease fulfilled the criteria I mentioned for dementia. And again, that doesn't mean that they're all in a nursing home or they're all unable to do most of their functioning on their own, but they've had some cognitive change and they've had enough functional change that they fit that criteria. This was a real eye-opener because I think a lot of people felt that dementia was very uncommon in Parkinson's disease. So this was a study that really changed the way we thought about Parkinson's and dementia. Is this important? Well, there were a number of other studies that have since come out that have been, I think, very critical as well. There was a group in the United Kingdom and a group in Australia that have followed patients with Parkinson's, similar to a dog study, different areas of the world though, and saw the same kind of thing. Very high rate, almost 80% by 15 years of disease of dementia in Parkinson's. But what they've also found was that it was often the cognitive changes, not the motor changes, that later in the disease were impacting the patient as well as the caregiver. So suddenly it became very clear it wasn't that the tremor had gotten so bad, but it was really that the patient was no longer able to do certain tasks that the caregiver had to take over, or the patient was upset because they couldn't do things that they used to be able to do. So we're finding that the cognitive and behavioral changes were a greater contributor to the sort of morbidity of the disease. We also noticed that people with dementia and Parkinson's were more likely to die. They had a higher mortality. And yet this was an area, again, up until 10, 15 years ago, that really almost had no research done on it. So this was an area where we really felt like we needed to do something because we didn't have medications, we didn't have an approach. It was not an area that had been studied very extensively. So what's the prevalence of Parkinson's dementia? Well, if you take all Parkinson patients across the board, I sort of said that your risk is about 80% by having 15 years of disease. But if you take everybody all at once, ranging from those just diagnosed to those who've had the disease for 30 years, about 40% of Parkinson patients will fulfill criteria for dementia, as I mentioned it before. This frequency is about 4 to 6 times greater than people without Parkinson's of a similar age. So it does seem to be linked to the Parkinson's as best we can tell. So going back to another Dag Arsland study, so what about just cognitive impairment, that sort of mild cognitive impairment, or MCI? So people with some cognitive change, but without sufficiently severe that it impacts their ability to take care of themselves, do their normal day-to-day activities. Well, one question has always been, is it present early on in the disease? Another question has been, maybe it's the medications. Maybe the medications are making the thinking a little slower or a little different than it used to be. And so Dog did a very nice study where he looked at new onset Parkinson patients who were not yet on medications and did detailed cognitive testing to see how frequently did we see impairments there. What you can see in this chart here is the results of his study, and what he found was that about 20% of Parkinson patients at the start of the disease without medication on board had evidence of cognitive decline. So they were more than a standard deviation and a half below the mean at that point. So Dog's conclusion from this really was that even early on there can be some modest, mild cognitive changes in Parkinson's disease. And I certainly, I know in my own clinical experience that a lot of patients will come in and say, I noticed early on, I was keeping my job and doing things, but it was harder for me in meetings, for example. It was easier to get off track. Or if I'm doing a task now and something else happens, it's hard for me to get back on task. Different kind of things than we hear from people with Alzheimer's disease, but definitely a cognitive change that people had noticed very early on in the disease. So these results were not a surprise to me. And this is just a quote from Dog that these findings highlight that cognitive impairment is a key feature even early in the diagnosis of Parkinson's disease. So I think we sort of established that this is something that does happen in Parkinson's. It happens to a mild degree very early, and well into the disease, it happens very frequently. One question I always get asked is this just Alzheimer's disease, or how does this differ from Alzheimer's disease? Well, generally speaking, what we find is it is different than Alzheimer's. Unlike Alzheimer's, it's much less of a memory problem. So classically, in Alzheimer's disease, as you can see off to the right here, usually the main problem in Parkinson's is an inability to store new information. And that means that they're doing okay when you're having a conversation, but if you come back to them 10 minutes later or an hour later, they don't often remember the details. So those of you who have had Alzheimer's in your family will often notice that this is one of the earliest symptoms. Forgetting conversations, not remembering a telephone call, not remembering appointments. And it can be somewhat patchy early on, but that generally is one of the main features early in the disease. In Parkinson's, I often hear people tell me they have memory complaints, but unlike Alzheimer's disease, they're often able to put new information in. They're able to store new information. Sometimes retrieving it's a little bit slower than it used to be, but it's in there. So very typically, I may give an Alzheimer patient, for example, 5 items to remember, wait a few minutes, ask them about other things, and then ask them for those 5 items. They won't remember the 5 items, and even with hints, they don't ping them up very well. Parkinson patients often, given the same test, they have a little trouble pulling up those 5 items a few minutes later, but if I give them hints, they often pull them all up, or they pull many of them up. So they're able to put that information or encode that information into their brain, but they're struggling to pull it out very rapidly. On the other hand, at least early in the disease, we see a little bit more executive function, particularly problems in Parkinson's disease. And so particularly in the area of, I've already mentioned, multitasking, attention, these sort of what I call almost immediate memory issues. So memory you're using as you're working along. It's very common for patients to complain to me if there's more than one thing going on at the same time, I'll get distracted and I get off the conversation. It's hard for me to keep up. Yet they're able to store information, again, different than Alzheimer's disease. Probably the best example of the multitasking I've heard was the wife of a patient of mine who said, you know, my husband drives okay, and we have conversations and they're great. But if I try to talk to him while he's driving, then we're really in danger. So that's sort of trying to do more than one thing at a time. I had another patient, a spouse recently tell me that her husband, who was very good at putting things together, needed to put a new lamp in their ceiling, and she said she turned the phones off and closed all the doors, and he did great. but it's very typical for him. If a call comes in and he gets off track, then it takes him twice as long to get it done. So getting off track, that sort of immediate memory issue, very common in Parkinson's. We see that less early on in Alzheimer's disease. In Alzheimer's disease, we tend to see, as the disease goes along, people develop language impairments, difficulty saying words, understanding the meaning of words. We rarely see that in Parkinson's disease. Sometimes coming up with a word on the spur of the moment is problematic, but actual language impairments, as we think of, like you see with a stroke, very uncommon in Parkinson's. Both diseases, to a degree, will have what we call visual spatial dysfunction. Tends to be a little bit more in Parkinson's disease, but we often have people reproduce figures like cubes and things. Those of you who've come to my research and have been tortured will remember those cubes I ask you to draw on things, and that's often something we see. Something we also tend to see again in Parkinson's is what we call bradyphrenia, which really means slow thinking. And it's different than what you might typically think of with slow thinking. It's not that you're thinking your content is abnormal. It's just that processing information takes longer. And so I actually have a colleague with Parkinson's disease, and the content of his thought is great. He's really a smart guy. Nothing has really changed in that area, but it takes him longer to get there. And I need to give him time as he's thinking things through. So that's what we tend to see, again, in Parkinson's. So that kind of gives you a general idea, but again, what we tend to see in Parkinson's is different than what we see in Alzheimer's. I think in many ways, I guess I have to say it's better. People are insightful. They know what's going on. It's not so much the memory issues. I guess the downside of being insightful is you know you're struggling with things, and that can often be obviously a problem. So what's going on in the brain? One of the big questions for many years was, as I said, when we thought it was pretty rare for Parkinson patients to get a dementia, people said, well, they're older, just happenstance got Alzheimer's too. So is it just Alzheimer's, or is it the Parkinson's? Well, one argument right away that it's probably the Parkinson's in a great deal is the fact that it's so frequent. Unless there's a common risk factor, it doesn't make sense that 80% of Parkinson patients would also get Alzheimer's. But the only way we can really know is to look in the brain and see what's going on. So what do we see in Parkinson's brain? Well, the main thing that we see is something called a Lewy body inclusion, or a Lewy body, L-E-W-Y, you can see here. This is, for those of us in Washington State, this is not Louie Louie like the song, but named after a guy named Friedrich Lewy, who was a pathologist, actually had worked with Alzheimer's, and described these inclusion bodies that are now linked to Parkinson's disease. And I believe a picture's worth 1,000 words, but which I'll get to here in a second. So what are these made up of? Well, the important thing to keep in mind is that these are made up of a protein primarily called alpha-synuclein. So you see alpha-synuclein here. And it's a protein we all have, but for whatever reason, it tends to aggregate in these brain cells, particularly the cells in the brain that make dopamine, and we think that it causes the cells to die. We don't know why it aggregates. If I knew the reason behind that, I'd certainly be a lot further along in my career. But we're trying to, it's one of the main things that we've been looking at is how this protein plays a role in Parkinson's disease. So when we look at the brain of somebody who's died with Parkinson's, one of the first areas we look at is an area called the substantia nigra. So on the left here is the part of the brain stem of an individual who died without Parkinson's. And you can see this pigmented line here, this area in dark, called the substantia nigra or substance black. This is a person who died with Parkinson's, and you can see it looks the same. In fact, if anything, it looks a little bigger here, but this part is gone. The cells that contain that pigment have died, and those pigmented cells contain dopamine. So if we look at those cells under the microscope, you can see this is a brain cell in that substantia nigra area. You can see that pigment in the cell, and I hope you can all see this circular structure here with a halo around it. This is a Lewy body. Body looks like, and again, it's mostly made up of this protein called alpha-synuclein that we think is so important in in the process of Parkinson's disease. We know, in fact, that people who have an abnormal alpha-synuclein gene either have a mutation in it or actually have extra copies of it are at high risk for developing Parkinson's disease. So that kind of is what's made us link that alpha-synuclein to Parkinson's disease. We also utilize the fact that alpha-synuclein's in these Lewy bodies to look in other areas of the brain, and in fact have found, I believe here, that not only do we see these Lewy bodies in the substantia nigra using the stain for alpha-synuclein, but we also see it in other parts of the brain, parts that we know are important in thinking, like the cortex, an area called the hippocampus that's important in memory. So we've seen now that the pathology occurs in a lot of areas. For example, one area we've seen it occurs very early on is in the olfactory bulbs, and many of you probably have heard the fact that olfaction or smell goes bad in a lot of patients with Parkinson's early on. Another area we know that gets involved is the gut, and we know that many people have constipation issues in Parkinson's disease, a very common issue. We think part of that's driven because these Lewy bodies are occurring in the gut. So what really has changed in the last few years is using this stain to detect these Lewy bodies. We found that they're in a lot of other areas, not just in these dopamine cells in the brain. So when you look at people who've died with Parkinson's dementia, how many of them have coexistent Alzheimer's and how many of them have those Lewy bodies? Well, this is sort of a compilation here of all the studies that I could find that I felt were done with an adequate scientific rigor. And you can see not a huge number of cases. But what was found basically was in about 97% of these cases, they had the Lewy bodies in the brain. So if you have Parkinson's and you develop dementia, it's highly likely you're going to have Lewy bodies in your brain. The frequency of Alzheimer's disease was around 15%, so fairly low. So while it may account for some of the dementia we see, it seems unlikely that it's accounting for a lot of the dementia. Did say I would talk about research, and this is a study we did recently. It's actually not published yet. It's under review, looking at another set of about 90 cases of Parkinson's dementia. And what we found basically was very similar to what was reported before, which was that about 38% had coexistent Alzheimer's disease. They all had Lewy bodies, which is very similar to this Galvin study. And similar to the Galvin study, I've starred this, is we used a pretty generous criteria for defining Alzheimer's disease. In fact, more generous than I typically use in my studies. So I think that figure's a little bit high. It's probably closer to 30%. That means that probably somewhere between 60 and 70% of Parkinson's dementia does not have Alzheimer's disease. So this is something that suggests it's being driven by the Parkinson's process, not because you're at higher risk for something like Alzheimer's. Are there other ways that we can look at this? Well, this is a study that we did a couple of years ago, looking at biomarkers in spinal fluid. And this is something that's done a lot in Alzheimer's disease. And in Alzheimer's disease, there are two major proteins that we see in Alzheimer's. One is one called amyloid, or A-beta here, and another one's called tau. And these are in the plaques and tangles that you may have heard of in Alzheimer's disease. And in Alzheimer's, what you see is that amyloid, because it's bound up in the brain, the levels go down in the spinal fluid. On the other hand, this tau protein actually goes up because it's released as cells die. It's in the cells in the brain. So one way to look and see if people with Parkinson's dementia are getting Alzheimer's is to look, is this A-beta low and the tau high? And of interest, what you can see here pretty much at the bottom here are people with cognitive changes in Parkinson's, is actually the amyloid does go down. So here's normal up here. The amyloid does go down, but actually the tau levels, if anything, also go down. So instead of going up like they do in Alzheimer's, they actually go down. This is very intriguing. I don't know, I want to get too much into the research, but another part of our research has suggested that the gene for tau, that certain changes in it are linked to your higher risk of Parkinson's disease. So we don't think this is the tangles of Alzheimer's, but there's some tau signal here, research-wise, that we're really wanting to look at a little bit more carefully. What's going on here? Why are the tau levels low, not the normal or high in Parkinson's disease? Interestingly, I'll talk about a PPMI study that we're doing at the University of Washington and around the world looking at biomarkers in early Parkinson's. And in fact, they've just confirmed this finding, that the amyloid goes down like you see in Alzheimer's and Parkinson's, but the tau also goes down. So there's something going on here we don't fully understand yet. So in summary, I think what our pathology and our biomarker studies have shown is that the majority of Parkinson's dementia is not due to coexistent Alzheimer's. The majority seems to be related to these Lewy body pathology. And again, as we develop treatments that are specific to Alzheimer's or Parkinson's, it's very important to know this, because if it were due to Alzheimer's, then we may want to give people with Parkinson's these Alzheimer drugs. And importantly, many of these Alzheimer drugs cause problems. They cause brain inflammation and other things. So I don't want to be giving it to a Parkinson patient. Number one, they don't have Alzheimer's. It's not going to help them, and it's only going to harm them. So this is part of, I kind of think, the future of treatment of Parkinson's is defining what's going on in a person and giving them the correct medications. So what do we have right now to treat cognitive changes in Parkinson's disease? Well, there's a little negative, but it's still funny, I think. This fellow says, I took a Gingo pill to boost my memory, a diet pill to boost my energy, and a Gingo pill to boost my memory. So actually, we have some treatments that actually seem to help in Parkinson's disease, at least to a modest effect. One of the things we know about Parkinson's is it does affect, as I mentioned, the dopamine cells, but it also affects another area of the brain called the basal forebrain, where there's a chemical called acetylcholine. Interestingly, that same area is affected in Alzheimer's disease. But unlike Alzheimer's, instead of the tangles of Alzheimer's, we see the Lewy bodies there. And in fact, it's one of the areas that Lewy described Lewy bodies when he first described them, was in this cholinergic area. So even though it's a different pathology, we get the same outcome, which is we get this deficit in this chemical called acetylcholine. This actually turns out to be an advantage, because it means that we can use the drugs that were developed for Alzheimer's to help with this cholinergic deficit for treating Parkinson's disease. So this is a little bit difficult file to see here, but this is just to prove that the acetylcholine levels are very low in Parkinson's disease. So this is normal, right? This line here is normal. These are different brain areas, but you can look at this top area here. And what you see here in dark is the deficit, about 10% in Alzheimer's disease. Here's the deficit in Parkinson's without dementia, which is about 15%. Here's the deficit in Parkinson's with dementia, 20%. So in fact, when many of us saw this data when it came out, we thought these cholinergic drugs that were developed for Alzheimer's might actually work better in Parkinson's disease dementia. And in fact, I think that's the case. And I'll show you some data to support that issue. So there are 3 drugs out there that we use to increase acetylcholine in the brain. Again, they originally were developed for Alzheimer's disease. The one most people know about is called donepezil or Aricept. There are 2 other ones called rivastigmine or Exelon and galantamine called Razidine. All 3 drugs increase the amount of this acetylcholine chemical in the brain, with the idea that it would help with thinking skills, originally again developed for Alzheimer's disease. There have been a number of studies trying to look at whether these drugs help people with Parkinson's dementia. The problem is most of the studies to date, but one, have been in very small numbers of patients, and the results have been very limited, have not been too exciting, but it's been hard to know how to interpret them because the number of cases they looked at were so small. So in fact, the differences would have had to have been profoundly large to see a difference when you have just a small number of patients. The one study I want to focus on is this 2005 Emory study using rivastigmine or Exelon. This was a study looking at a very large number of patients, 541. Most of the patients were in Europe. This was a European-based study. There were a few in Canada. The US was not a site for this study. But the bottom line, I'll go into more detail in a minute here, is that everything that they looked at were modestly improved with the drug versus placebo, and that included cognitive, behavioral, and functional benefits. So it was really quite an impressive study from that point of view, because typically in the Alzheimer's studies, they've had trouble finding improvements and beyond just the cognitive testing. So this is a study. I don't know how well you can see it all, but what they saw was a significant improvement in a variety of scales, and this was looking at people on drug versus people on a placebo. So it was a placebo-controlled trial. Every test that they looked at related to cognition got significantly better. Something called the ADAS-Cog, which kind of has global memory. Mini mental scale, which many of you know. Fluency for pulling up words was faster. Clock drawing even was better. Activities of daily living were better, and even behaviors were better. So none of these effects were dramatic. It wasn't like some people, you put them on Cinemet and the tremor goes completely away. So I don't want to oversell it. But actually, it's one of the better cognitive studies I've ever seen in terms of response to therapy. What are the side effects? Well, rivastigmine or Exelon is notorious when it's taken orally for giving nausea. And so what you can see here is nausea and vomiting were significantly higher in patients on this drug than people on placebo. Although many of you know now that this Exelon comes in a patch formulation, which really lowers that nausea and vomiting side effect, although some people get a skin irritation. So nothing is free of charge, right? Anything you take. But those are the significant side effects. There was a worry that it might worsen tremor. For those of you who have Parkinson's for a while, you know that sometimes we use an anticholinergic to treat tremor. And so by giving a cholinergic drug, increasing acetylcholine, does it make tremor worse? And in fact, we did see a slight effect, or they did, I wasn't a part of this study, a slight increase in tremor. 10% of people on pill complained of more tremor versus 4% of people on placebo. Now, when they went back and they looked at formal testing of tremor, there was no difference between the two groups. So it's a modest effect, but it's something that can be noticed as a side effect that can worsen tremor. On the positive side, which I thought was very interesting, is many of us have noticed when we've treated patients with Exelon or any of the other cholinergic drugs, to be honest with you, we anecdotally have had families come back and say, yeah, they're a little sharper in their immediate memory and so forth, but it's kind of funny, the hallucinations they had went away. That there was maybe a little bit of an anti-hallucination effect. And if you look down here, they kind of looked at this from a side effect point of view, but in the placebo group, about 10% of patients had worsening of hallucinations as they were on the placebo, but about 5% of the people on drugs. So half the number of people on the drug had worsening of their hallucinations. So this sort of supported this thing that we were seeing anecdotally, that maybe not only can help a bit with cognition, but there may be a bit of an anti-hallucination effect. So the other drug that's been available for a long time for treating cognitive changes in Alzheimer's is a drug called memantine or namenda. It's been approved for treatment of Alzheimer's disease. Theoretically, it actually has been linked to maybe having a positive effect in Alzheimer's and Parkinson's disease. There have been 2 clinical trials looking at it, one done by the Dag Arsland again in Denmark, another by Marat Emery, who did the Exelon study. And their findings have been pretty modest. You can see in this chart, this is a global scale. And this is a clinician seeing a patient in clinic, not knowing if the patient's on placebo or pill, and assessing, are they the same, which is right here? Are they getting worse? or are they getting better? And what you can see here is that in red are people on the memantine or namenda, in blue are people on placebo, and you can see in general people on the placebo were reported as being the same or worse, and in general people on the drug were more likely to be improved. This effect was very modest. It actually was not confirmed in a subsequent study. So it's not clear if namenda is really helpful. I'd have to say in my own clinical practice, this is off-label, I do tend to add it to one of the cholinergic drugs like the Exelon with the hope to get a little extra boost, and I do get at least reported benefits. But whether it hasn't been, I think, adequately scientifically proven yet. So what do we do for cognitive change in Parkinson's? Well, I think the main thing that we focus on is when somebody's having a cognitive complaint, I try to get them on one of these cholinergic drugs, the Exelon, the Aricept, the Razodine, trying to optimize their thinking skills. I often will add namenda later on if they have further progression. The effects are modest, but again, I'm trying to maintain people and their thinking as best I can. So what's the good news and bad news? Well, the good news is it's not Alzheimer's most of the time. These treatments do seem to help, and in fact, if anything, they help better than they help in Parkinson's than they help in Alzheimer's. And then I'll talk a little bit later about some of our research. The not so good news is this is very common. And I'd like to say that it isn't common or we have the perfect treatment, but we're not there yet, but that's why we need to do the research that we're doing. So I want to spend the rest of my talk talking about some other non-motor symptoms that are very common. In fact, I was just in a meeting before I came down here where we're talking about trying to get money to do a study of something called REM sleep behavior disorder, or RBD. RBD is a sleep problem where people act out their dreams. Typically, the patient doesn't notice it, but the family members will notice it, because they're thrashing around and they're yelling. And the spouse will wake them up and say, "You're thrashing around and you hit me." And they'll tell you that they were being chased or they're chasing somebody, some sort of threat, and they get very active. What's very interesting about REM sleep disorder is there was a paper that came out last year that showed that people with REM sleep disorder alone were very likely to develop Parkinson's or one of the related Lewy body disorders within about 10 years, about 50%. What was also interesting is some people had that sleep disorder up to 20 years before they developed something like Parkinson's disease. So it's very much linked to Parkinson's and the Lewy body pathology, but it's something that can happen much before the disease progresses. So my research project, or our research project actually that we're hoping to get funding for, is to look at those people because it'll tell us what's happening perhaps very early in this disease process when we want to intervene. What are the biological processes going on very early on? So this, again, a common problem, acting out dreams. Sometimes the best solution is, I had one patient where the wife said, I asked her, does he wake you up at night acting out his dreams? And she said, no. And then I said, well, how long does he sleep at night? And she goes, I really don't know because I sleep in another room because he used to wake me up acting out his dreams. So in her case, she just moved to another room and that sort of solved the problem. There are some medications that seem to help. The first thing I usually use is melatonin. Anywhere up to 12 to 15 milligrams at bedtime can sometimes suppress that acting out. Another drug called clonazepam or Klonopin is very effective, but it's very sedating. And so a lot of people will tell me the next day they're very sleepy. So I sort of use that as a second-line drug, or in people where they're really having trouble. I've had a couple people who fall out of bed and have hurt themselves, so where we really do need to treat it. It's also important to recognize that Parkinson's is associated with a number of other sleep disorders. Sleep apnea is very common. Periodic leg movements, something called restless leg, where you, as you get in bed at night, you feel like you got to get up and move. These are very common, and so for people who come to me where it's pretty complicated in terms of what's going on, I usually do recommend they get a sleep study, because it's very common for Parkinson's patients to have more than one sleep disorder. But again, for treatment-wise, we do have some treatments that seem to help this REM sleep disorder. Visual hallucinations are something that are very common in Parkinson's. It's reported that in people who live up to 20 years with their Parkinson's, about 3/4 will have had a hallucination at some point in the course of their disease, usually visual hallucinations. They're often formed. They're not always frightening. Many patients, I think when I was first getting into the field, I remember one of my patients telling me that he had this man that followed him everywhere he went. And he said, even when I work out in my tool, shed, he's standing right beside me. I thought, well, wow, that's kind of spooky. And he goes, no, he's kind of kept me company. I felt pretty comfortable with him there. So that was one of my first introductions, that often the hallucinations are not threatening. People see children playing in the front yard. Frequently they recognize that they're not real, or they ask their spouse or somebody if they're real or not. And in that circumstance, we often don't treat, because the treatments can be have pretty significant side effects. But when they are frightening, when people are calling the police, calling 911 because they're scared, because there's somebody trying to get into the house, or what are all these people doing in the house, that sort of thing, then we do tend to treat. One of the things, if it's happening in the context of a dementia, I'll often use one of these cholinergic drugs, try to suppress them. If it's really problematic, then I often do have to use an antipsychotic. Quetiapine is the one I use. I think that's sort of the one most people in the field use. Clozapine is another one we often use, but requires weekly blood tests for one of its side effects. So usually we're going to use something called seroquel quetiapine, which is a scary drug. It generally doesn't make the motor symptoms of Parkinson's worse, which is good, but it is a little sedating. And particularly for people who are in nursing homes, sedation means you're at higher risk of developing things like pneumonia and so forth. And so we do see a higher rate of death in nursing home patients who are taking these drugs. So I'm always very cautious about when I start them. But for some people, it's a quality of life issue. So this was my favorite hallucination. This was a man who told me he saw squirrels driving tractors in his front yards. Those of you who see me talk, this is my most frequent hallucination I report. So I was very curious. I said, like little toy tractors or big ones? And he said, no, big ones. And if you look, their little arms were having trouble reaching the arms, reaching the steering wheel. So these can be very well formed and very interesting. And I thought this was the best one, but recently somebody said they saw chickens riding unicycles. So I have to get my graphic artist to put that one together for me for a new picture. Another behavioral symptom very common in Parkinson's is depression. Probably occurs up to half of people with Parkinson's. It's a part of the disease. That's one of the things. I mean, there's obviously the emotional reaction to having a disease like Parkinson's, but we also know that the dopamine in your brain is very reinforcing. And if your dopamine levels are going down as you get the disease, it's not surprising that your mood goes down. In fact, one of the best acute mood elevators, cocaine, actually elevates dopamine in the brain. So I always say Parkinson's is sort of like the anti-cocaine. It's like you're not taking cocaine. And so it's a very common problem. And I mention that because I want people to get it treated, because often it's very responsive to the antidepressants. It's a part of the disease. It's not a weakness. It's not something you have to fight through. It's better just to go ahead and get it treated most of the time, because the treatments can be often quite effective. And you have plenty of other things to deal with. Why not be a little bit happier and able to deal with those things with a better mood? Anxiety is very common, often in the context of medication wearing off. Very interestingly, I've often linked it to anxiety as you got stiffer and your motor symptoms got worse. But one of the DBS people, and I can't remember if it was the fellow out in Spokane or somebody locally, was telling me that he was noticing that he had several patients who were getting anxious after DBS as their medicine wore off, even though they had no motor worsening. So just the medication, there's something about the dopamine and the anxiety system in the brain that are somehow linked together as well. So it's something typically what we'll try to do for anxiety is to move the medications closer together. In the circumstances of DBS, they just re-up the medicine a little bit. So even though the patient didn't need it for motor, they actually needed a little bit for their anxiety. Another behavioral symptom we see a lot is something we call apathy, which is reduced drive to do things. Some of that's just because you're tired. It's a little harder to move. It's harder to get things done. Some of it is literally there's this sort of, again, internal drive to do things. We've often noticed that the cholinergic drugs will help improve apathy, so that's something we often do. I think the other thing that I often find is that it's just helpful to have scheduled activities. So I often recommend people have something that they're scheduled, because we all do this, right? We're all say we're going to go to the gym, 3 times, 4 times a week, and we don't do it. But if we have a trainer who's waiting for us and we have an appointment, we're more likely to make it. Same thing there. Trying to get people out of the house, a trainer, a group that you get together with, walk once a week, twice a week, 3 times a week. But scheduled activities often help get over this sort of inability to get yourself motivated and moving. Compulsive disorder is something we've heard a lot about. Again, we know dopamine's very reinforcing. We're playing with the dopamine system with medications. So it's not surprising completely that we're starting to see some of these, what we call impulse control disorders. The ones you may have heard about most are gambling. Before we recognized that this was a side effect of some of the drugs with Parkinson's, we had people losing hundreds of thousands of dollars, literally. And it's very easy right now, right? You put your credit card number in online and you can play cards all night. You can lose everything that's on your credit card. And I've had spouses come in and say, I didn't know anything was going on until my credit card was rejected, and they said it was completely, maxed out. And patients will tell you, when they come off the medications that often aggravate this, they don't know what was going on. They were driven to do this, and as soon as they come off the medication, the drive goes away. So I've had people who never gambled all their lives, suddenly it gets very reinforcing. You've seen some hypersexuality activity and other things. I had a woman who said she couldn't stop knitting, which seems odd, but she said she knew she was in trouble because she was on a camping trip and she'd been knitting for something like 6 hours and was in her sleeping bag at 3 a.m. knitting, and so felt like something had to be done. And actually, usually what we do is we withdraw, particularly the dopamine agonists have been linked to this side effect. We see it with Sinemet, but we see it more with the dopamine agonist. And in this woman's circumstance, as soon as she came off the dopamine agonist, that drive went away. She was back to knitting a couple hours a week. So something to keep in mind. And I like to keep it in mind both for patients, caregivers, and as clinicians as well, to keep it in mind so we can keep an eye open for it so we don't run into trouble. This was a recent study a friend of mine, Dan Weintraub at University of Pennsylvania did, looking systematically at these impulse control disorders. And basically what he found was that any of the treatments, including dopamine agonists and Sinemet, can increase your risk for these impulse control disorders, but it is worse with the dopamine agonist than what we see with Sinemet. And that's typically what I've seen clinically, is more problems there. What are the risk factors? Well, these are the risk factors that came out of a study. Age played a role. Interestingly, it was a Canadian and U.S. study, and so living in the U.S. increased your risk, and I'm not sure why that would be, but that came out. A family history of gambling issues. Again, dopamine treatment, agonist treatment was the highest risk factor, but not far behind was levodopa treatment. I thought what was interesting is there were also some gender differences. So there was no gender difference on the problem gambling, but there was a difference in that women tended to be a higher risk of compulsive buying than men, but men tended to have a higher risk of compulsive sexual activity. Although I did have one person say, do we really know it's a difference in compulsive sexual activity is problematic, or is it just that the wives are more likely to complain about men's hypersexuality versus the other way around? So, but there do seem to be some gender differences here. Other things that I think were coming into play now, we know there are autonomic differences. We talked about constipation, blood pressure management, sensory changes. I've had a number of patients now who've come to me who for years were diagnosed with arthritis, and then it became more clearly Parkinsonian, went on meds, and their arthritis went away. So early on, joint stiffness and things can often be a symptom of the disease. Fatigue, I think increasing focus on how important fatigue is. Visual changes, probably linked to some degree to the hallucinations, but difficulty interpreting visual information. As I said, I often have people draw a cube for me, and I had one patient said, I can't draw it because the cube keeps moving back and forth on this piece of paper. So it was very, very interesting in terms of these visual perceptual changes. The last thing I leave to the last, because I always leave it to last in my clinic appointments, is driving. So she says, Marie, are you still driving? So this is particularly important in the context of dementia. There is some evidence that particularly if you have dementia, that your risk for getting in an accident is greater. But I also like to look at it, I think importantly, from a legal risk point of view, which is if you get in an accident, even if it's not your fault, the fact that you've been diagnosed with Parkinson's dementia or cognitive impairment could be used against you in a court of law. And having done some legal work, I can certainly see it happening. And I've actually seen it happen on the Alzheimer's side. When I was in Chicago training, we had a patient who was backing out of his driveway, and a motorcycle came by and hit the back of his car, and the motorcycle was speeding. But he actually lost the legal case, partly because they said, how do we know with Alzheimer's he wouldn't have made, if he didn't have the Alzheimer's, he wouldn't have made a better decision or paid more attention or seen this guy coming down the road. It's not fair, but it's a reality. So typically what I usually do is I have people get their driving tested. I don't think I can assess if somebody can drive or not. And I think I have patients with Parkinson's and dementia who can still drive. But what I typically do is I get people formally tested, both to know how good your driving is, but also to have a legal document so that if they say you can drive, and you've got some legal protection that you've had your driving evaluated. So it's something I do. And I think it's important as a clinician to help people explore options if driving is no longer an option. What are other possibilities? And it's tough. I think for those of you out in other sites, I mean, when I have people come in from Eastern Washington, for example, I mean, they live a long way from public transportation. This is not a small issue. At the same time, I don't want you getting hurt, hurting someone else, or finding yourself in some legal battle. Which is not a good way to spend your time. So where do we go from here? Well, one of the things is education, both for patients, caregivers, and definitely clinicians, advocacy, and research. We have a number of research projects here at the University of Washington and the VA hospital focused particularly on non-motor complications of Parkinson's disease. We have a registry of people who are willing to be and interested in participating in any of our research projects, and this is a registry we use to let people know about research that's going on. By being in the registry, you don't agree to being in research, you just agree to being contacted about research. And we have 3 main studies we're doing now. One is, as I said, the Pacific Northwest Udall Center. This is focused on cognition, where we follow people longitudinally over time. We also have a study called the PPMI, which is looking at biomarkers in untreated Parkinson patients. And we need both patients who are untreated, but we also need controls for that study. And then we have a genetic study. So for those of you who even out in Montana and Alaska, it's always a possibility that you can participate just by donating a blood sample. Because we're always looking at the genetics of Parkinson's disease. I'm going to kind of skip ahead and just do my last here. We need your help. This is the Parkinson's Registry here. You can go to registerparkinsons.org online. This is a phone number in case you can write fast. But we're always interested in having people participate. We have close to 1,500 people with Parkinson's in our registry now. So it's really been quite successful, but we can always use more help. And obviously we can't study the disease in the real disease if we don't have people with the disease helping us out. And I just want to thank for support from all the groups here in Washington State have been great, patients and their families, caregivers, and of course all my collaborators here and throughout the country and world. So thank you very much.
Okay.
All right.
Go that on that side.
On this side, okay.
You'll be more in.
Are we going to?
I'm
Are you
gonna-
going to? You know how to use this?
Yeah.
Oh, okay.
Okay, well, thank you, Dr. Leverenz. That was really helpful, and certainly on behalf of Northwest Parkinson's Foundation, we would really strongly encourage everyone to sign up to be a part of the study. It's completely confidential. I mean, you know, nobody knows you're in it, sort of thing. But you are the folks that can make the difference going forward. So you have that number, and if you don't, be sure and check in with us. So I'm going to bring Dr. Leverenz back up on the screen. I'm going to try. And then we'll check in with each center, and you can ask your questions. I'm going to zoom in on him so you can see him. And if you would repeat the questions when we hear them.
I will do my best, yes. So I'm going to move a little closer here so we
All right,
can
I'm gonna,
get.
Okay, so I'll call out each of the different centers. And if you would then unmute your mic at the time we call you out. And if you have any questions, open your mic and you can ask the question and Dr. Leverenz will respond. So it looks like we have Anchorage should be there today. And we'll just wait a second. I know the technology takes a little minute to see if we can connect. Okay, nothing from Anchorage. How about Billings, Montana? I'm sure hoping they're clicking into them. Spokane, can you tell me if you're able to click into those different sites at this time? Should I be muting or no?
I see.
Hi,
This
We're
is the
not
bridge
able
here
to
in Spokane. Those locations are still connected. They're just not opening their mics for questions.
Okay, well, we'll keep moving down and see if anybody else clicks in. Clarkston?
Yes, we have two questions here, and when this comes from out of Spokane, they ask us how many people are here, so I'm going to tell you that. We have 19 people here, and we have two separate questions. Number one, the driving test that you were suggesting, where does one go to get that test to the actual Washington State driver's license place? And I'll ask my second question in a minute.
Okay, that's a very good question. So there are a number of ways you can have your driving tested. You can get it done through the Department of Licensing, at least in the state of Washington you can. Each state may be slightly different. Usually you need to have a physician sign off on the form, but if you go to the Department of Licensing, they usually can give you instructions on how to do that. Oftentimes you can do it through occupational therapist. So for example, I do a lot of my clinical practice at the VA hospital in Seattle, and we have an occupational therapist who that's what she does all day, every day, is driving evaluations for a variety of purposes, but including people with Parkinson's disease. So usually it's either an occupational therapist or through the Department of Licensing.
Okay, thank you. And number two, another question that someone has asked, have you ever heard of the discussion of coconut oil helping in dementia or Alzheimer's?
So her question is, have I heard anything about coconut oil for treatment of Alzheimer's or dementia? And yes, this has been a hot topic over the last about 3-4 weeks. So I had not heard about that until about a month ago, and now I get asked every time I give a talk about coconut oil. So it's as far as I can tell, mostly what's been apparently there's a YouTube video that I actually took a look at last week that shows somebody before and after coconut oil and miraculously look much better with the coconut oil. But as far as I know, there have been no systematic studies. I believe, though, in fact, that there is a controlled trial that's underway in the United Kingdom looking at an extract of coconut oil to see if that's helpful with the disease. So I can't say yay or nay at this point in terms of coconut oil, other than to say there's enough interest that there is a study going on in the United Kingdom. I don't know of one going on here in the States.
Well, yeah, that YouTube one you're talking about, they show the man is drawing the clock, and he gets it all screwy, and then after being on the coconut oil for a while, he's drawing the clock perfectly, and he's vacuuming. I think we've all seen that same YouTube. Anyway,
Okay.
Thank you, and that's all the questions for Claxton.
Okay, thank you.
Thanks, Clarkson. If you would remute yourselves. We'll go to Coeur d'Alene.
We don't have any questions here. We have 13 people in attendance.
How many?
13.
Great, thank you. Okay, next would be Colville.
Hi, I had a question regarding sleep disorders. You talked about REM sleep behavior disorder, acting out dreams, and the fact that it sometimes responds to clozanapam. My husband is taking clozanapam, and from time to time he does act out dreams, and I was wondering whether it's just a factor of not maybe having enough of it, or what might continue him getting that, and is there any danger other than maybe falling out of bed or hitting me?
Right, there's a very good question. So the question really is about clonazepam and REM sleep, and in your specific case, the medicine he's taking isn't completely suppressing the REM sleep disorder. Really, I think first and foremost, there isn't a big danger to it, other than, as I said, the major danger usually is to the caregiver getting hit, or I'd say it's rare that the patients fall out of bed, but I've had a couple where they did that, where we were a little more aggressive in treatment. But I think if somebody's generally suppressed with the clonazepam or with a melatonin treatment, and there's no, the caregiver feels fairly safe, and the patient's not falling out of bed, then I usually don't change treatment. So there's nothing wrong with letting it happen periodically. Really, it's a matter of how much inconvenience it is. And some people, I just leave it alone. A patient and the family say, no, we're pretty comfortable, it's just not that big a deal. I think that the important part of REM sleep disorder really is it's linked to Parkinson's and to Lewy body disorders. So I think we're going to hear more and more about that as time goes along.
Thank you. We have another question here in Colville.
You talked about the study, the only large study using cholinergic drugs for cognitive disorder. And you mentioned that was rivastigmine. Does Aricept act by the same mechanism? Would you then expect that Aricept would work the same way?
That's a very good question, of course. So her question really is, we had the one big study done with rivastigmine or Exelon in Parkinson's dementia that showed a positive effect. What about the other cholinergic drugs like Aricept and Razidine? And they work in very similar ways, but they're not identical. So I can't say for sure that we know that they work. But typically, if somebody with Parkinson's, for example, comes into my clinic and they're already taking Aricept, I usually don't switch them off. But if I'm starting somebody anew, I'm probably more likely to start the Exelon. And that, although there are a number of issues that come up with that. For example, at the VA hospital, Exelon is not first line. And for some people, it's more expensive. So you have to take all of those things into consideration. Again, I don't know that they work identical, but they probably work very, very similarly.
Thank you.
Thank you.
Good question.
Okay, thank you. We'll move on to Dayton. Any questions from Dayton?
No questions from Dayton, and there's 4 of us here. and we've enjoyed the
Okay.
program greatly.
Thank you. No one there. How about Grangeville, Idaho? Okay, how about Kennewick? And anybody at Kirkland? Yes, we have a question at Kirkland.
Doctor, you didn't mention dystonia. Is that very common in Parkinson's, again, cognitive or any relationship? What is the relationship?
So the question we have here in Kirkland is there any relationship between dystonias and cognitive impairment? And as far as I know, we haven't seen a relationship between them. We are actually, another study that we're starting to look at in our sample. We have, in our Udall Center now, we have about 600 patients we're following, and we're starting to parcel those sorts of questions out. So we're looking at not only things like dystonia, but what side of the body your Parkinson's started on. Did you start predominantly with tremor or with a non-tremor predominant Parkinson's? So we're starting to look at, are there links between the motor symptoms that you're experiencing and cognitive impairment or the kind of cognitive impairment you're having? But don't have the answers to those questions yet.
There's a possibility.
There's a possibility, yes. For example, I don't know about dystonia, but I know in the literature there's a little bit of evidence that whether you started, and I don't remember which side it is, but if you started on one side versus the other, you're more likely to have certain kind of cognitive problems. And we know that there's an asymmetry to the brain, and for example, the left brain is more important for language, and the right brain may be more important for visual spatial. So we may find that there's some association there. We're just getting to the point now where we have the data to start to try to answer those questions, and we are working on that.
And the link of the disease can have something to do as well.
Well, there's no doubt that the longer you have the disease, you're higher risk for developing dementia, yes. So,
The other things too.
right.
Thank you very much.
Welcome.
Any other questions in Kirkland? Okay. Let's move on to Miles City, Montana. Any questions? Does that look like an empty room? Okay. How about Pendleton?
Yes, we have one question.
Okay.
Is there any difference between the drug Azilect and Rasagiline?
Yeah, so it's a good question. So Azilect and Rasagiline are the same drug. There are two drugs in that class, though. There's Selegiline and Rasagiline. And I think there's, again, somewhat similar to the previous discussion I had about Aricept versus Exelon versus Razidine. There haven't been really good head-to-head studies between those two drugs. And it's kind of an important issue for a number of reasons. One is Azilect or Rasagiline has had some evidence that maybe it slows progression of disease. We're not convinced of that yet, but we're very interested in that. Selegiline has been around for a long time and is substantially less expensive. So there's a lot of debate, and I think we don't really have the answers to it, but a lot of debate about should we start somebody on a cheaper drug like Selegiline, or should we use the drug that has been demonstrated to maybe have a disease slowing effect, and we really don't know the answer. Selegiline may do the same thing, we just don't know.
Any other questions from Pendleton? Do you have 7 folks there today?
No, we had 13 and one dog.
Okay, wow, that's a good showing. Thank you. 13 plus 1. All right, how about Port Townsend? All right, Pullman, Washington.
I think the thing to do is ask your doctor, you could just call.
And Pendleton, if you could mute your button again. How about Ritzville? Okay, well, let's check in with Spokane. I know we always have a large group there. Any questions in Spokane today?
Yes, Spokane has 32 in attendance today, and we have at least a couple of questions.
All right.
I was surprised to hear that anxiety was getting to be common in Parkinson's. I've had Parkinson's 15 years. My husband has Alzheimer's. And lately I am feeling some anxiety. It sounds like I'm teary now, but I didn't realize that they were together. Is there something help that anxiety?
I'll repeat the question.
I may have to have you repeat the question. Maybe we can close the door behind here too. It was difficult to hear exactly what you were saying. I heard something about anxiety, but then I didn't hear much more specifics.
I was surprised to hear that you had to say that anxiety had something to do with Parkinson's. And I have been having anxiety lately and not knowing why. I have had Parkinson's for about 15 years, and my husband now has Alzheimer's. I thought maybe that was causing some of it, but it sounds like anxiety is a step of Parkinson's. Is that correct?
Right. I think that's a good question. So as I understand it, your question is you were surprised that anxiety was something that could be linked to Parkinson's, and I think it's a surprise to many of us, but not surprising in a sense that again we're dealing with a disease of the brain, and again I think most of what we've seen is linked to the medication. It's also important to recognize, much like other behavioral disturbances, that other factors can play a role. But I think it's important to mention it to your doctor who's helping you manage your Parkinson's disease, because sometimes a change in the way the medicine's given can be helpful. So if you're getting, for example, anxiety as your medicine is wearing off, you may need to move the doses closer together, things of that nature. So it's always good to recognize that can be a problem in Parkinson's so that your doctor knows and can help see if they can help you manage that better.
Okay, we have another question here.
Yes, in your talk you mentioned a number of European studies and other places. How does U.S. research stack up internationally?
Okay, so the question I'm hearing is how does U.S. Research stack up against non-U.S. or European studies? I think we do generally very well. There's no doubt that the research funding that can be received in the U.S. is really a lot better than most other places, with the exception maybe of like the United Kingdom, France, maybe Japan, but we probably still have the greatest research funding, which is always helpful. There are some things that have happened in terms of what we call institutional review boards that review clinical studies that have become, for lack of a better term, somewhat cumbersome in recent years, and it does slow often it slows our ability to get going on a clinical trial rapidly. It's just a lot of paperwork and a lot of review. And so sometimes all of these places have these so-called IRBs, but some places are a little quicker than others. So you will tend to see the companies working with a country or a place where these IRBs are faster. I'm not sure the U.S. is #1 in speed of IRB approvals.
And yeah, we do have a follow-up to that.
It's a different question. I've been sort of diagnosed with Parkinson's now for maybe 2 years, but it's dismayed me a little bit that when I've seen a number of neurologists, they seem to have one diagnosis, which is Parkinson's, and they have one treatment, which is Sinemet or dopamine. I mean, do you see something brighter in the future than that?
Well, certainly I'm always hopeful. I think we have a number of agents that can be used. I mentioned the dopamine agonist. We talked earlier about Azilect or Rasagiline and Selegiline. I still use quite a bit of carbidopa, levodopa, or Sinemet. We also use the medications I've already mentioned to treat some of the non-motor side effects of the disease. But there's always lots of work going on. Even on the motor side, you're seeing a lot of work being done to try to make the effect of the dose more even through the day, so you're not having ups and downs. And then on the cognitive side, there are other medications that are being worked on. And of course, our hope is that we have some treatments that actually have disease-specific treatment that actually slow the progression of the disease or stop it. And we're all working hard for those. And part of the work that we do, for example, with the Michael J. Fox funded PPMI study, is we're trying to find ways of documenting whether the disease is progressing or not biologically, so that we can tell if a drug is actually slowing the disease or is it just treating the symptoms of the disease.
Okay, and we do have another question yet.
Okay.
I've been taking Azilect for over a year, and I'm wondering if I swap to the generic, if I can go like Azilect and the generic on and off.
Well, the Azilect specifically, or rasagiline, does not come in a generic form. There's a similar drug called selegiline that is generic. It is less expensive. And I think there's a lot of debate out there whether it's equivalent or not. And I'd have to say, you know, and you'll, if you talk to 100 movement disorder specialists, you'd probably, you know, you get a pretty even split on whether they would make that switch or not. And then some of it even comes down to economics. The Azilect is not cheap. And if you're having troubles affording it, then I often will make a switch. At the VA hospital, we are required to start people on selegiline if we're going to choose one of those two drugs. And so most of our patients there are on selegiline. But we don't really have good head-to-head studies at this point to know if they're equivalent or not.
And one more question. For sleep apnea, are there any treatments other than surgery or those hellacious positive breathing devices?
Well, I'm not a sleep expert, but those are the two main treatments. So the question is about sleep apnea and surgery, the CPAP machines, the forced breathing machines, so to speak. You know, I think the one thing I would say to people is to work with your sleep doctor. If you've got one of those positive pressure breathing machines and it's not working for you, talk to your doctor about other types of machines or other kinds of options. I just think it's good to explore options and not give up after one try, because I've had a lot of people go home with a CPAP machine. They didn't like it, they stopped it, they never went back to see if anything was better. And there are a variety of CPAPs. Sometimes they don't fit right. There's some that just fit in the nose. There are a variety of options there. And sometimes that means you go to surgery depending on how severe your sleep apnea is. There's no medication that seems to be particularly helpful that I'm aware of.
Thank you. No further questions from Spokane.
Thank you.
Thank you, Spokane. Okay, Tenasket.
7 people and 1 question.
Okay, how many? 7?
Yes, 7.
Okay, ask your question.
Okay. I have a sleep problem in that I don't sleep enough. I average about, I would say, 5 hours in 24 because I stay up all night sometimes playing computer games, and I just lose track of time totally. So is this due to the Parkinson's, and can there be something done about it? Or am I just going through my second childhood?
So I'll reiterate your question, which is that you're having some sleep disturbance. In particular, you're not sleeping a lot of hours, but also your day-night schedule has gotten messed up. So you're up
Yes.
late at night and sleeping some during the day. Not an uncommon problem. I see it in people. My guess is some of it's related to Parkinson's, in that we know that the sleep centers in the brain can be affected by the disease. And so sleep cycle isn't as natural as it used to be. So one of the things that I preach is what we call sleep hygiene, which really means that you try to structure your day and night cycle a little bit better. What that means usually is you try to do things during the day that keep you up. I can't generally force people to sleep at night until they're sleepy. And if you're sleeping during the day, then you're not going to be sleepy at night. So the first step usually is making you very sleepy by keeping you up during the day, so you're more likely to sleep at night. And typically that is things like structured activities. You know, I know there's not maybe a lot of structured activities in Tonasket. I don't know that for sure. But something that you can do to keep yourself active during the day so you're not sleeping and napping. And then I think another good sleep hygiene, usually what people recommend, the sleep experts I work with, will tell me, you know, you pick a room where you don't have computer access, where you don't have a TV, and it's just there for sleeping, and you go there when it's time to go to bed. And you know, maybe you set yourself an alarm or something, and you say, okay, at this point I am going to go to my bedroom, my sleep room, and there's none of these distractors are there. Those are usually the best things. I find medication to be often not very helpful, and I think it's much better to try to get your clock back on time, and which means usually more activity during the day, and honestly somewhat difficult, but a little bit more discipline at night. Are you taking a dopamine agonist?
No, I don't think so. I take L-Dopa.
Uh-huh.
The
You're not taking
L-Dopa.
Requip or Mirapex?
I take Requip.
Okay. So
For
you
the
might want to
restless
talk to
legs.
your treating physician about that, because it's possible that some of this compulsive behavior, the compulsive computer use, is being driven by that. So you may want to talk to your doctor about that
All right.
as well.
I will, and thank you very much.
You're welcome.
Okay, and our last site today is Walla Walla. Okay, well, Dr. Leverenz, this is fabulous. I know it's just so important to everyone to have knowledge about what's going on in the research side. I mean, I think we all live with the challenges of this disease every day, but really hearing from the expert and knowing that you're really devoted and committed to this research is really fabulous. So thank you very much for being here today. Thank you to all our sites, and I would just like to make one more comment, kind of a save the date. Coming in August, Northwest Parkinson's Foundation is going to be doing a conference, Inland Northwest Hope Conference on Parkinson's. August 25th, it'll be at the Northern Quest Resort. So mark your calendars if you haven't had a chance to come to the Hope Conference in Seattle. We're going to try and come there and put on a good conference for everyone there. So until next month, thank you for joining us, and be well and take care.